Hello everyone, welcome to the first glaucoma session here at COS. I am Toby Chen from Kitchener, Ontario, and I'm here with my co-moderator, Dr. Lisa Gold from Winnipeg, our esteemed panelists, Dr. Cindy Hannick from London, Ontario, Dr. Bryce Ford from Calgary, Alberta, and Dr. Bal Chauhan from Halifax, Nova Scotia. So we have an action-packed agenda today, and I would encourage everyone, if you have any questions to the speakers, please use the Q&A function in the bottom of the screen to submit questions anytime. So we can go over them during the discussion periods. Now let's start with part one of this session, titled Glaucoma Care in Canada, State of Affairs. I'd like to introduce our first speaker, Dr. Bryce Ford, who's our president of the Canadian Glaucoma Society. He will speak to us on glaucoma practice during and after the COVID pandemic. Thank you, Bryce.
First off, thank you everyone for giving me the opportunity to speak. So far I've been very impressed by the caliber of this talks and also the audiovisual, myself excluded, quality of the presentations, considering this is the first time we've really done this virtually. I know we are on a time schedule, so I'll try to stay right on time. I'm going to be talking about how do we manage glaucoma during and after the COVID pandemic. I have no relevant disclosures. So obviously COVID-19 is the topic on the forefront of everybody's mind these days globally. It's interesting, a couple points about it. It's the first coronavirus to cause a pandemic. There have been other ones from a number of different pathogens, but this is the first coronavirus. The last pandemic was actually H1N1 in 2009, or swine flu is what we called it at the time. So COVID-19 is having a huge impact on all aspects of really human society globally. So let's look a bit at the impacts on healthcare. So we think about waves related to a pandemic. So, and I'm not talking like first wave, potentially second wave in the fall, where the COVID itself comes back. But if we think about the first wave of COVID-19 mortality is just specifically related to that illness, related to COVID. And of course it has big impacts, but I just want to show you how it has aftershocks that may be even bigger than COVID itself. So the second wave of after a pandemic is the untreated acute disease that's related to COVID. So these are the heart attacks, the retinal detachments, the acute glaucomas that happen and are untreated either because your healthcare system cannot handle it because of COVID or because of reluctance of people to go in because they're concerned about COVID. And these will have significant sequelae which may actually dwarf, much like our little guy on the bottom right there, who's settling in after the first wave and then getting pounded by the second wave. These will have potentially greater effects on our healthcare system than actual COVID. And then the third wave, and this is where our management of glaucoma really comes in, is untreated chronic disease due to COVID. So this is looking at POAG, glaucoma, hypertension, diabetes, these types of conditions where when everyone is focused on COVID, very little preventative medicine is being done relative to chronic disease. And as a result, these conditions are not going away. In fact, they're probably just getting worse over that time. And the sequelae of these we'll see for years to come. As an example, our glaucoma patients who we haven't seen for several months, perhaps with pseudoexfoliation, and they missed their visits or we were shut down and only seeing urgent patients and maybe their pressure's been up over that time. And the long-term consequences of that will be seen for years to come. And then the fourth wave is mental health issues related to COVID, which we don't deal with quite as much. But this is the anxiety, depression related to the disease itself or to other health issues or just to loss of safety, loss of jobs, financial distress related to COVID. So as eye care providers, what should we do during a pandemic? So we have an obligation, obviously, to keep ourselves safe, our staff and our patients, right? We also have to not lose sight of the fact that we are eye care providers and we have to look after our patients to prevent those second and third waves from really dwarfing the original COVID pandemic. So in a sense, we have competing interests there. We want to look after our patients, but we also want to remain safe. And really, as you look, what we want to do in this case is flatten this curve. If we deliver optimum eye care, we're probably maximizing the risk, but we want to maintain good eye care while minimizing the risk. So we're flattening a different type of curve in our own offices. And how do we balance that? So what we need to do is minimize the risk of transmitting COVID in our offices and yet still meet the eye care needs of our patient population, because that's obviously essential. So what the COS and the CGS have tried to do together is come up with some guidelines on how best to manage your office in the setting of the pandemic. And our recommendations in April were really, just to summarize, really see only urgent patients, use strict infection precautions, and no elective surgery. And these guidelines are available on the COS Practice Resource Center. As things have started to open up, we've updated our guidelines. In June 9th, we came up with a second set, and now we're suggesting that you can see urgent and routine patients. You can see all your patients, really. However, we still have to maintain strict infection precautions and physical distancing in our office. So masking, keep your chairs far apart. Our waiting room only has like 4 chairs in it, where it used to have 20. So we really need to maintain that physical distancing throughout the patient encounter. And then elective surgery, we've resumed it here in Calgary, and I think that's okay as long as, again, waiting rooms, all the physical distancing measures are in place. Now, we don't have any current or any plan to update these guidelines, because I think for the foreseeable future, we do not foresee any changes to this, either for better or for worse. Hopefully not for worse. Ideally, we will at some point be able to loosen these restrictions and go back to things the way they were before, but right now that's not really on the horizon. So going forward, if this persists beyond 6 months, 1 year, 2 years, hopefully technology can help us out with some of this managing of our patients. And there may be new ways that we can come up with to examine our patients, like home IOP monitoring, teleglaucoma, or technological innovation. I know that the number of people interested in these virtual reality headset visual field machines, we certainly are interested in them. There are none licensed in Canada right now, but they would be easier to clean in your setting, or even for patients to do at home and bring in the information. But we've got to look at other ways we can manage patients while minimizing the risk to them. So in conclusion, we all have to stay safe, ourselves, our patients, office, and we need to use proven methods to avoid being a source of infection, including physical distancing, masks, barriers, and infection protocols. We had a patient come through our office about a month ago from Cargill who tested positive 2 days after. But due to us all having adequate PPE, he came in twice because he was an urgent patient and he was booked for surgery. He came in twice, saw my booking associates, and nobody got infected, none of our patients, none of us, because we were using appropriate PPE. And I think that to some extent validates what we're doing. So I think we need to just continue to do that. And the goal is we still need to provide eye care to minimize the subsequent waves of untreated disease. Thank you very much. One upside of this is there's a lot of funny memes that have come out related to COVID. So I've enjoyed all those, which are a little bit of a silver lining to the cloud of COVID. Thanks very much.
Thanks a lot, Bryce. Yeah, I certainly hope my hand wouldn't turn into that. And just to want to chime in about the Practice Resource Center, there's a lot of updated good resource on the website. So please, everyone, be on the lookout for that. Now, I think we do have a question from the audience. Question is it ethical to refuse to see an office patient if he or she refuses to wear a mask because of not believing in it, quote unquote? What do you think of that, Bryce? Welcome all the panelists to chime in as well.
So we don't mandate that patients have to wear masks. We recommend them. We're all wearing masks, and I would say 80 or 90% of our patients do have masks. You know, there's obviously been some issues at stores where they mandate people have to wear masks, and there's some non-believers out there who don't, you know, and conspiracy theorists, whatever it is, that really are not interested in wearing a mask. In our office, as it stands, we have not excluded them from their eye care, but we do recommend it.
And what I've seen, Toby, I don't know if you've noticed this in Ontario, there seems to be a lot of variability. Some practices are very strict. If you don't have a mask and if you don't bring your own mask, they tell you they're going to rebook your appointment. But there's been concerns, several concerns. One is just the cost of the PPE, who's going to provide the cost should the patients be sent to buy a mask and then come back. There's so many issues, and I'd like to get an answer from the panelists. What do you do about the masks causing a lot of fogging up of your lenses? Are you actually proceeding to tape the masks on your patients' faces? Because I don't know about you, but my views of the optic nerve are very quick now because the patient's breath are fogging up my handheld lenses. So from the ophthalmologists in the group, what do you do about that?
Well, I have the shield on the slit lamp. So if I find it's a problem, I do get them to lower the mask just for that part of the exam. We aren't insisting that everybody wear masks, but we're encouraging it. The only time we're insisting it is for the visual field. Yeah.
For the interest of time, I may save those other questions till later. I'm just gonna move on to introduce our next speaker, Dr. Matthew Quinn from Queen's University, who's gonna speak to us on longitudinal, sorry, I lost my screen there, longitudinal trends in interdisciplinary care for new glaucoma patients in Ontario. Thank you, Matthew.
All right, thank you. I'm just attempting to share my video here and share my screen. So is everybody hearing me and seeing the slides?
Yes.
Excellent. All right, so
Dr. Quinn, your camera is still off.
yeah,
Start
okay.
your video.
It says unable to start because the host has stopped it. So I'm not sure who to turn to for a fix there. But maybe I'll just get rolling with the slides then. Okay, here we go. And I'm back. Very good. Thanks for the introduction. There are no relevant disclosures here. Learning objectives as follows: to compare between ophthalmologists and optometrists in Ontario, trends in the rate of diagnosis of glaucoma suspects and trends in the rate of treatment of new glaucoma patients, and also to identify patient-level predictors of the type of eye care provider. As we know in this audience, optometrists in many jurisdictions may treat certain eye diseases. In Ontario, optometrists have been able to prescribe glaucoma medications as of 2011. While this has been rationalized as a means to improve access to eye care, we don't really know, we don't have the data to say, has this actually happened? So the purpose of this study was twofold. The first, to determine the impact of the expanding scope of optometry in Ontario on how new glaucoma patients are distributed between ophthalmologists and optometrists. And as a second objective here, to determine patient-level predictors of the type of glaucoma care provider. In brief, this is a longitudinal retrospective population-based study. We used linked healthcare databases from the province of Ontario. We included patients who were in one of two categories. The first, nominally glaucoma suspects, patients who had received a glaucoma diagnosis without subsequently receiving any glaucoma therapy. We also included newly treated glaucoma patients, so a patient receiving first-line intervention, either topical medication or a laser trabeculoplasty. Study window from 2007 to 2018, we included only patients over the age of 66. This is because in Ontario, universal drug coverage begins at the age of 65, so this gives us a one-year look back to exclude patients with previous medication use. We also excluded patients with previous filtering surgery and ALT or SLT. For the suspect group, we excluded patients with a previous glaucoma diagnosis. In other words, we wanted only newly diagnosed suspects or newly treated patients. Briefly, our analysis, we examined and extracted patient-level covariates from population-based databases. These included past ocular history factors, demographic factors, and past medical history factors. We examined population-based rates of glaucoma suspect diagnosis and therapy initiation. We looked at therapy initiations per provider, and then finally, to address the second objective from earlier, we undertook a logistic regression analysis to examine predictors of provider type. Moving on to some results. I'll distill the important features from this table in a second, but this essentially shows baseline characteristics of the entire cohort. So both newly diagnosed suspects and newly treated patients grouped according to provider. You'll note that we use standardized difference as our measurement of statistical significance, specifically a threshold of greater than 0.1. This is used because in population-based studies of this size, the p-value is almost always small. The key findings here: ophthalmology patients tend to be older, they tend to live in urban areas, and often have higher comorbidity. This figure shows the rates of glaucoma suspect diagnosis over the study window. This is expressed as a rate per 100,000 persons in the population over age 66. For both providers, ophthalmology in black and optometry in gray, we see that there's an increase over the course of the study. In 2018, the most recent year, we see that nearly 60% of newly diagnosed suspects are diagnosed by ophthalmologists. This figure, this is a separate group of patients here. Also a rate per 100,000. This is therapy initiation for new glaucoma patients. And the key finding here is the gray line. So indeed, beginning in 2011, therapy initiations by optometry increases annually. However, it remains quite a bit below what we're seeing from ophthalmology. So in 2018, nearly 90% of newly treated patients are treated by ophthalmologists. Just to back up a second, we know that in Ontario, the number of optometrists outnumbers ophthalmologists by about 3 to 1. So how do we explain the discrepancy in distribution for care? So we examined the number of therapy initiations per provider. So over the study window, ophthalmologists, the average ophthalmologist, if you will, is initiating therapy in a median of about 25 patients each year. In contrast, for the average optometrist, that's either 1 or 2 patients they are starting therapy in per year. So quite a bit of a difference there. So we see that there are some differences in the scope of practice and the distribution between the different categories of eye care providers. So we also asked the question, what factors determine if a patient receives that care from an ophthalmologist versus from an optometrist? This question was answered, or we attempted to answer this with a multivariable logistic regression model. The model shown on the right here. The key findings, care from an ophthalmologist is predicted by increasing age, female sex, lower socioeconomic status, which is probably a consequence of certain diagnostic testing not being universally covered in optometric practice. Care from an ophthalmologist is also predicted by urban residents. This makes sense. Ophthalmologists tend to set up shop in urban areas, as well as a history of intraocular surgery and increasing systemic comorbidity. These patients are already in the medical system, so they're more likely to fall under the care of a physician. Study has some important strengths. The size of the study, more than 400,000 persons included. It's a topical question. Scope expansion for optometry is evolving in a number of jurisdictions. Major limitations would include that we included only patients over the age of 66, as previously mentioned, and also generalizability to other jurisdictions really should be done cautiously when there are significant differences in how different providers are paid, essentially. To conclude, ophthalmologists in Ontario, optometrists in Ontario have always played a significant role in terms of numbers in the diagnosis of glaucoma suspects, and this continues to be their predominant role. In contrast, despite these providers having the authority to prescribe medication for the better part of a decade, in 2018, they are initiating therapy in just over 10% of all patients starting therapy, so a much smaller role there. It seems that low rates per provider prescribing are implicated, and I think that really the take home here is that more work is required to sort out why optometrists aren't treating more. Thank you.
Thanks, Matthew. Any questions from our panel?
Matthew, was this your hypothesis? Was this consistent? Because what a lot of people were saying when the TPA came through, that optometrists would be more likely to initiate treatment earlier because of concerns of missing disease. But what you found here is there's a hesitancy. So is this sort of against what the hypothesis was? And what do you think the reason behind it? Is it an educational reason, a liability reason, political reason?
Sure.
What do you think?
Yeah, so to address the first part of your question, was this what we expected? I don't think this was. I mean, we expected to see increasing rates over time, which we saw, but ideally, or perhaps more likely we would have expected to see the numbers converge as far as what's happening with ophthalmologists versus optometrists. As far as what's driving that, one of the challenges with our study design is we didn't look at what happens from a patient who was seen by an optometrist who is subsequently referred to an ophthalmologist. If that ophthalmologist then starts therapy, that patient is counted under the ophthalmologist cohort, if you will. So it's possible that optometrists are referring those patients who maybe we would prefer they'd be starting therapy, given that they have this authority, so to speak, to do so. So that's maybe one limitation, that we can't capture those patients. As far as other reasons, things that come to mind, training, it just doesn't, call it practice efficiency or differences in fee codes for what an ophthalmologist gets paid versus what an optometrist gets paid. It just may be not worth their time in some instances to have a significant component of their practice that's based on glaucoma therapeutics.
One question I would ask is that I think when you talk about optometrists managing glaucoma independently, I think that optometrists have as their main asset geographic diversity, meaning they're in the small towns where your patients would have to travel to see ophthalmologists, or it's a challenge for them to see ophthalmologists in the big city. Whereas our main asset is our level of training. So I think that when you say that maybe we should use the optometrists more to manage glaucoma, I think that's valid, but I think that there's a caveat to that, that if patients have access to an ophthalmologist, I think anyone would admit that that would be optimal care. And that if there's an optometrist and ophthalmologist side by side and the patient has equal access to both, I think that seeing an ophthalmologist would be optimal. However, I think optometrists do have the role if it's in the setting where ophthalmology care is not that accessible.
Sorry, so I think we'll move on to part 2 of our session on glaucoma diagnostics. I'm going to pass the virtual mic to Dr. Lisa Gold.